I'm the chair of the Latino Health Forum that this year is in the 28th anniversary. This forum was started by the Sutter Family Medicine Residency Program, and it came bigger and bigger through the years because by myself, I'm going to remove my mask, and but this is to remind you that it's been proven that using your mask, your mascarilla, your cubrebocas is so crucial to try to prevent this more spreading of this disease. We are very happy to have Dr. Sundari Mase, Public Health Officer, that I will talk about a few minutes in a second. So the problem that we've seen is that the pandemic is spreading, and the Latino population, Latinx population, is being more affected in our county, and probably in many other counties in California. And I'm not sure in other places, but people of color are being more affected, and this is because, and that's the name of the conference this year, discrimination and health. So we clearly seen that the disparity in income makes people more susceptible to get sick and die than the population with a better income. So we thank you very much for participate. It's going to be every day for the next 7 days, except during the weekend. And we have wonderful speakers that very kindly are giving their time to talk to you. The idea is to inform you, because more information you have, more power you have, and more free you are. That's for sure. We know that many of our loyal group of people that comes to the Latino Health Forum every year work with Latino families, Latinx families, and then this information is going to be crucial for you, so you can do even a better job that you're doing. I know that you're doing a wonderful job without so many resources sometimes. Well, it's really a pleasure and an honor to introduce Dr. Sundari Mase, that is our public health officer. As I said before, she has been in the county for not too long, and the welcome was very challenging with this pandemic. But she has been doing an amazing job as a professor of the UCSF and as a physician. I can tell you, she's been doing an amazing job and help a lot in to control this pandemic in our county. Dr. Mase did her undergraduate degree. She got it at University of California, Berkeley. And then she went to medical school at UCSF, University of California, San Francisco, where she finished her internal medicine residency, then went back to the alma mater of University of California, Berkeley, and did a master's in public health with emphasis in epidemiology. She's an assistant professor at the Infectious Disease Department at Emory University, and she has served as an associate clinical professor at UCSF. Dr. Sundari Mase, thank you very much for taking the time, and I'm sure that people will find your talk very, very good and interesting. Thank you. Welcome.
Thank you so much. It's a pleasure to be here. Thank you, Dr. Enrique, for a really nice introduction. I am really honored to be able to present on this very important topic of the disparities in COVID-19 in the Latino or Latinx community. The purpose of this briefing today is to provide an overview of the efforts from the Department of Public Health Operations Center to provide outreach, information, services to the Latinx community, and to respond to ending and mitigating the disproportionate rates of COVID-19 among the Latinx community. It was such a surprise to us and so disheartening to see these disparities that we know exist anyhow, again, manifest through COVID-19. So what I'd like to do is, over the course of the next 55 minutes or so, give some background on the novel coronavirus and put sort of things in perspective so that people understand what we're dealing with. Then I'd like to speak specifically to some of the epidemiology we've seen, just generally here in Sonoma County, and then focus on the Latinx community and talk about what we've seen and maybe some of the reasons for why we're seeing what we're seeing with COVID-19 in the Latinx community. And then I want to talk about what efforts we've actually gone to try to mitigate and address the disparity that we see that is just so frightening, really. So as a little bit of background, and many of you probably know this, the novel coronavirus was identified in December 2019 in China, Wuhan City, Hubei province, and it was initially detected as just a cluster of pneumonia cases in persons who had some local exposure to the local open air markets. So this is where a lot of viruses stem because it's often animal to human transmission, which I'm going to get into. So we think perhaps that the coronavirus had already been spreading for maybe even a couple of months in this area by the time it was actually detected. So the coronaviruses, what are they? Well, they're enveloped single-strand RNA viruses. And as I said, they've been shown to go from animals to human beings, and they're found in both animals and human beings. In fact, the coronavirus is the kind of virus that causes the common cold. And as you know, we, at this point, have no vaccine for the common cold. And in fact, all of us get the common cold, if not every year, even more often. So the four most common strains that circulate worldwide are as the ones that you see listed here. What more do we know now about coronaviruses? Well, we know that they cause epidemics in human beings. There's been 2 documented types of coronavirus that have already gone from animals to humans and caused epidemics. The first one was the severe acute respiratory syndrome, or SARS, that some of you might remember, happened from 2002 to 2004, causing 8,093 cases with 774 deaths. Actually, that's a very high case fatality rate of almost 10%. The cases were identified again in China, Hong Kong, Taiwan, and then in Canada, we had 8 cases identified in US residents, all of whom had travel exposure. And after the investigation was over, it was found that bats were the reservoir, and likely the coronavirus came from civets. Civets are a type of cat that's found in the wild. And again, SARS didn't really take hold in the United States, given that we only had 8 cases. But the first case actually landed in Santa Clara County, right here in California. Then we had, and that sort of died out over time. And as you can see, it didn't become anything like what we're facing now. Then we had the Middle East Respiratory Syndrome, or MERS. That happened in 2012 and has caused close to 2,500 cases with 858 deaths, which is actually a much higher case fatality rate of 34%. Which is actually quite scary when you think about it, that 1 in 3 people who got MERS actually met a fatal outcome. The majority of cases occurred in Saudi Arabia, and we've only had 2 cases here in the United States in residents that traveled to Saudi Arabia. Again, bats were identified as reservoir, but the virus is transmitted via camels. So you can see different animal species can be involved with transmission of these viruses. But again, these 2 viruses didn't really take hold in the United States and they weren't as easily transmitted from person to person as the novel coronavirus COVID-19 that we're dealing with today. So COVID-19, why the name COVID-19? CO stands for corona, the VI for virus, and D for disease. And 2019 was the year in which it was found, which is why we call it COVID-19. SARS-CoV-2 is the virus itself, and you can see here an electron micrograph representation of the virus itself. What's our current situation? We have over 4 million total cases in the United States. And now we have close to 144,000 total deaths. And you can see our case rate is 1,228 cases per 100,000 population. If anything, COVID is on the rise in the United States. And many of you who've been following the news know that initially we were really able to flatten the curve here in the United States and California and in Sonoma County by sheltering in place. In other words, having everybody stay at home. But since we've started reopening, as many experts, including me, predicted, we would have an increase in cases because this virus is transmitted from person to person very easily through the airborne route, through coughing, through talking, singing, and also through direct contact from person to person. So what are we seeing in California specifically? As of July 23rd, in California, we had 435,334 total cases, and that was up by almost 10,000 cases in the 24-hour period. So you can see here we've had over, we've had 8,000 fatalities, which is quite significant, and it's very scary, I think, for our state. If you look at the ages, we are seeing most of our cases in people who are young adults or middle-aged adults. We're seeing the majority in the 18 to 49-year-old age group, followed by the 50 to 64-year-old age group. And I think the reason for this is that these are the people who are out and about. Initially, they were the essential workers that were out in the workforce with the businesses that never closed down, like the grocery stores, the pharmacies, healthcare facilities, farm workers, food and beverage production, manufacturing to support essential services. So this is where we're seeing the most cases, but we are actually seeing a lot of cases in people over 65 and in our kids. Close to 50,000 cases in California and those over 65, and 38,301 in children as of July 23rd. It looks like COVID is impacting male and female about the same. So gender doesn't seem to make a big difference in this disease. So I think the take-home message here is everybody's getting COVID, but it's people who are out and about with more exposure that are likely getting COVID more. As you know, our schools have closed down since March, and that may be a reason why we're not seeing as many cases in children. In Sonoma County, we now are up to close to 2,500 total cases, and it's been pretty steady. A little bit of an exponential rise after we started reopening. We've been having somewhere between 50 to, I would say, 100 cases a day, probably an average of around 50 to 60 a day over the last several weeks. Of these, about half are active and about half have recovered, meaning that they are no longer infectious. And once they pass 10 days of isolation, plus 1 day of being without symptoms, if they had symptoms ever, they're considered recovered. We've now had 24 total deaths, and our deaths are being driven by cases in the elderly population, especially those people who are in our skilled nursing facilities or our residential care facilities and board and care homes for the elderly. Here's our case rate. Case rate is just a number of cases per 100,000 population. As you know, we have 500,000 people here in Sonoma County. Since sort of the end of June, beginning of July, we've been seeing a case rate of over 100 per 100,000. This is the reason why the governor and the state's medical officer shut down certain really risky activities here in Sonoma County with a state order for closure of indoor restaurants, indoor wineries, indoor family entertainment centers, movie theaters, card rooms, and all bars and breweries. We also had a shutdown of other risky activities because of direct contact, like personal services, massage parlors, tattoo parlors, hair salons, barbershops. All of those also had to close down because our case rate is over 100 per 100,000. As you can see, over the course of the last, I would say, 3 weeks to 4 weeks, we've had case rates that have been somewhere around 50 per 100,000. And we need to start seeing this decrease before we can start reopening. Luckily, our testing capacity has been quite good. We have a capacity to do 800 to 900 tests per day. And our goal was to be able to perform about 750 tests per day, given our population. The CDC and CDPH stated a goal of 150 tests per 100,000 population, which equals about 750 tests per day for Sonoma County. We've been exceeding this, being able to perform 879 tests per day as an average daily testing volume. So there we're doing well, and you know there's several sites. Santa Rosa and Petaluma have OptumServe, state-funded sites that are doing testing of about 500 to 600 individuals a day. We're also doing a lot of pop-up testing, as I'm going to speak about, for high-risk groups, including Latinx populations, through the Public Health Department. If you take a look at where people are getting their infection, early on, as you can see here, our cases were really occurring in people who traveled. This is the travel you can see right here, but also in people who are contacts to cases, people who are household members of a case, or those people who work with somebody who had COVID in close circumstances, in van pools or car pools. And then we had a lower number of community cases. Let me stop here and make sure you're seeing my arrow. Are you able to see my arrow as I'm speaking?
Yes.
Oh, good. Want to make sure I was in the right screen there. So over the weeks, we've seen, as the Public Health Department started doing a lot more testing of close household contacts and worksite contacts, we started to see more and more cases occurring in close contacts. And this is a good thing because we were identifying these people. We knew where they were getting COVID, and we went out and tested everybody, both symptomatic and asymptomatic. And the travel-related cases pretty much went away because nobody was traveling due to shelter in place. Now, since mid-May, when we started to reopen retail businesses for curbside pickup first and then for actual walk-in, when we started opening indoor restaurants, it's outdoor and indoor restaurants, the wineries, the gyms, different things, you can see that we still had a lot of cases in contacts, but we started seeing more community, more community transmission. That's in sort of this mustard color here. The reason for that is as COVID spreads in the community, there are more and more asymptomatic people who could have COVID and not know that they have COVID that are out and about spreading or transmitting COVID. So community transmission means a case that happens in somebody with no known exposure. They didn't have a family member that they knew had COVID. They weren't identified as having a worksite exposure, or they didn't travel to a place where there was a lot of COVID. So as you can see, since we started opening, we've definitely had more cases of community transmission, but a lot of contact cases because we've had more and more outbreaks in families, large households, work sites, healthcare facilities, really every sector we're having outbreaks now. And over the past month, we in the health department are trying our very best to keep on top of all these cases, but in the last few weeks especially, many of our cases are still under investigation, meaning we're needing to find out where we think their exposure was. And you can see we've had more cases due to travel because people are traveling from county to county and they're traveling domestically within the United States. These travel cases are not happening due to international travel at this time. So of the 849 cases reported over the last 3 weeks, our epidemiologists have looked at these cases very closely. About 72% have actually been evaluated for their exposure. And of these, about 3/4 were occurring in close contacts, about 16.5% community acquired. And this is significant. These are cases where we don't know exactly where they're coming from, but they're popping up in the community. And 7% due to travel. That's increased again over time. So when you look at the close contacts, just those, these 76.5%, 47% had household contact with somebody who had COVID-19. So they are high risk and had exposure in a household setting. 18% became infected at their workplace. This is up from 5% about 6 weeks ago and 10% about 4 weeks ago. So what that means is there's been more transmission occurring in the workplace. 6% had both workplace and household exposures, meaning that they worked with household members. 14% were exposed in congregate care, meaning they lived in a facility, like a skilled nursing facility or a board and care home. And this is very important to underline. 14% were exposed at gatherings. And as you know, we've really been trying to put out the message, we need to limit gatherings because this is where we're seeing transmission. And it can even be gatherings with extended family, gatherings with friends, gatherings with people from the same workplace. But we did see an increase in spike in cases from 4th of July, barbecues, Father's Day gatherings, birthday parties, bridal showers, funerals, etc. And this is an important area where we can actually intervene to make a difference. Now, if you look at where the workplace transmission, I said there was 18% of our cases happening in the last 3 weeks due to workplace transmission. Of these, the majority were in services and sales. And as you know, we opened up some retail businesses about a month ago. Healthcare, which is always a high risk because healthcare workers are the ones seeing persons with COVID. Construction and landscaping. This is very interesting because there's a lot of involvement of the Latinx community in construction landscaping and in service and sales and agriculture, manufacturing and food production. Construction has been open from day one because construction was felt to be an essential function. And landscaping has been open longer than most other areas. Agriculture has always been open in terms of farm workers, vineyard workers, food and beverage production as well. Public safety, these are our law enforcement and firefighters and EMS staff, and then manufacturing that supports these. So that's where we're seeing the transmission in terms of work sites. So if you look at just the community transmission cases, again, cases that pop up in individuals that had no other reason to have COVID, you'll see that 60% had no known exposure. So people do a lot of things. We go and ask them in the last 14 days before becoming a case, what all activities did you do? And not surprisingly, people go to the gym, they go to restaurants, they might go to a bar, they might go to the park, they could go to a zoo or museum. So it's really hard sometimes to kind of nail down where they went, but they did not mention things like grocery stores, gatherings, etc. Of the 40 cases who did list some exposure, 14 listed gatherings. Again, there is a common denominator here. When people get together and when they have gatherings, we are seeing transmission. Additionally, you can see here that 11 people listed necessary activities such as grocery stores, healthcare visits, pharmacies, bank, gas stations. 9 had possible workplace or household exposures. 5 actually mentioned restaurants, bars, or salons. And 1 was a homeless individual. So what this tells us is that we are definitely seeing community transmission in places that we've recently opened, like restaurants, bars, and necessary activities that have always been open. But again, a common denominator is gatherings, and it makes me feel that we really need to focus on getting the message out that we should really limit gatherings with people that we don't live with, that we don't spend a lot of time with. Because if you think about it, even if you're seeing your cousin or another relative or a family friend, depending on where that person has been in the last 2 weeks, you're being exposed to all the places that person has been as well. So if you take a look at the travel exposures, 30 cases reported travel outside of California, but interestingly enough, also for out of vacations and visiting family and attending functions such as funerals and other gatherings. So again, gatherings is a common denominator. 15 cases reported travel within California for work in other counties or visiting family. And another thing that really came out was that ride sharing without the use of facial coverings in vans or cars with non-household members could be a possible contributing factor for infection in cases involving transportation within the county as well as travel outside of the county. So it's very important to wear a facial covering or a mask when in vehicles with people who are non-household members. If you take a look at our cases by age group, as I've broken down before, and this is broken down even further, the majority of our cases are occurring in the 18 to 54 a year category, but a good proportion also in our children. Children are mainly getting COVID because they're household contacts to adults who are cases. Not many cases occurring in the very young children. Maybe we're not picking them up because they could be more asymptomatic. And not as many in the older generation, which is really good because this is the group that's having really negative outcomes from COVID. And this probably means that people over the age of 55 are really staying at home still and sheltering in place, despite the fact that people in this category are, that younger age groups are out and about. So now let's flip to the impact on the Latinx community. Again, the disproportionate number of cases is just incredible. You can see here, very important to look at the numbers, 67% of our cases are occurring in people who self-describe as being Hispanic or Latino. And this group only makes up 27% of the population, whereas 26% or a quarter of our cases are occurring in those people who self-describe as being white, non-Hispanic, and they make up 65% of the population. We're not seeing a lot of cases in other non-Hispanic groups or Asian Pacific Islander non-Hispanic groups, and they also make up a small percentage of the population. So if you look at the case rate is about 9 or 10 times higher in Latinx communities than in the white non-Hispanic and other non-Hispanic groups. Latinx cases are younger because, again, they're probably the people who are out working from day one, the people we considered our essential workers in agriculture and food. I'm going to show you the breakdown of where in just a second. And they're more often due to close contact transmission because a lot of transmission is happening in households with close contact. In fact, that's where all the children are getting COVID, is from being contacts in households. More often they show no symptoms. Why? Because we're testing all of our contacts, both those with symptoms and those without symptoms. So a higher proportion of Latinx cases we're finding to be asymptomatic because we're going out and testing them, even though they're asymptomatic when they're contacts. And they're less likely to have an underlying condition or be hospitalized because they're younger. It's the older people with COVID that have an underlying condition like diabetes or heart disease or lung disease, and it's the older populations that are more likely to be hospitalized. So let me show you this in more detail now. Latinx COVID cases were more likely than non-Latinx cases to be younger because you can see that this is really happening in the kids who are household contacts. Latinx is the mustard color, and the sort of green or khaki color is a non-Latinx. So in the age groups of 0 to 4, 5 to 17, 18 to 24, 25 to 34, and 35 to 44, cases are predominantly occurring in Latinx groups. A little bit more equal in the 45 to 54 year age group, but still more in the Latinx. And then if you look at the older groups, substantially less in the Latinx group, suggesting that it's people who are out working in the Latinx community and their kids in households that are being infected. Latinx COVID-19 cases were more likely than non-Latinx cases to have an exposure that was a close contact. Again, because of the large households in which there's contact that we're seeing cases develop. Not as much community transmission, which is good. Definitely not as much travel-related cases in the Latinx opposed to non-Latinx. And so really this is about transmission of COVID in close contact settings like households and work sites where people travel and work together. So Latinx COVID cases were more likely than non-Latinx to live in the central part of the county, Santa Rosa, Cotati, Rohnert Park. The majority of our cases already are occurring in people who live in urban centers in the central part of the county. But there's a disparity in Latinx versus non-Latinx in that area. Not as many Latinx cases occurring in the South County, about the same in North, less in the East County and the West County. So really the urban centers are where we're seeing a lot of our cases. Latinx COVID-19 cases were more likely than non-Latinx cases to be asymptomatic, as you can see here, and less likely to be hospitalized. Again, this data is because younger people in the Latinx community are getting COVID. As you saw, it was the kids and people under age 55. Really, the 5 through age 54 age group. And those groups, because they're younger, are more likely or less likely to ever be hospitalized. And as far as asymptomatic, it's because we're testing people who are contacts. And again, the Latinx COVID-19 cases were more likely to have no underlying conditions because they're younger. So they're not as likely to have underlying heart disease, hypertension, lung disease. But interestingly, they're less likely to have ever smoked, which I think may speak to the fact that maybe in the Latinx population, people either don't smoke as much as in non-Latinx, or they're not saying that they smoked. Either one it could be. So let's look at what work sectors where we're seeing disparities in the Latinx group. Again, this is not where transmission is happening, because we saw only 18% of cases are due to worksite transmission. What this is telling us is where people with COVID-19 work, not that they actually got it at their workplace, but just where they work. There's a huge disparity in the Latinx people in all the cases in agricultural and farm work occurring in Latinx. A little bit more in service and sale, but not a big difference. More in the unemployed group, more in construction and related trades, more in manufacturing, environmental services, food and beverage production, caregiver and personal help, landscaping, outdoor maintenance, transportation, sanitation, public works, and definitely this is probably from just a few numbers in students. In the non-Latinx self-described group, there's many more cases than those not working and sheltering in place in all likelihood, and recently out and about, not working. In healthcare, professional or managerial, and public safety. That would be law enforcement, fire, and emergency medical services. And I want to note, many of these places where we see disparities in the workplace, these are the essential businesses that have been open from day one. So as a result of working in essential sectors like agricultural and farm work, food and beverage production, in the manufacturing and in caregiver, personal health, landscaping, construction, people in the Latinx community are just more at risk because they were working when others were sheltering in place. Again, this just underlines where the cases are occurring, where the disparities in the Latinx are. So if you take a look at the cumulative COVID-19 cases by week of onset of symptoms, you can see the Latinx again is this line here, kind of mustard line. Non-Latinx are the green line. The starting in early April, the huge disparity began in cases in the Latinx. Now with a 265% increase in this period of time, and there's been an increase in the other group as well, but many more cases in the Latinx over the time frame up until the end of June. It's very important to note. And this is happening in every age group. Again, the 18 to 34-year-old age group has been hit the hardest, especially since sort of mid-May when we started reopening. Likely because this is the group that's out and about doing things, not just working, but also perhaps going to bars. This is nationwide. We're seeing younger adults. That's the group in which we're seeing more and more cases as bars, restaurants, gyms, personal care, like hair salons, barbershops open up. But then 35 to 49-year-old age group is next. Less than 18, the kids, this may be from transmission in households as well. And the older groups are definitely not seeing as much of an increase. And thank goodness, because this over 65-year-old group is where we're seeing almost all of our deaths due to COVID here in Sonoma County. Now, let's look at the different strategies we've used now for dealing with COVID. Containment was the initial strategy. Shelter in place. That was restrictions on movement, monitoring and restriction of travel, isolation and quarantine of cases and contacts, and intensive case investigation. Now we're still doing these two things, isolating cases, quarantining contacts, and doing the intensive case investigation to find secondary cases. In other words, if somebody is found to be a case, our nurses perform a case interview and they identify where that person has been since they were infectious and who all they came in contact to. And we identify all the people that case could have come in contact to for more than 15 minutes. And we call all those contacts and we tell the case, the person who has COVID, to stay isolated in their room with a private bath. If they can't do that, we offer them an alternate care site where they can actually go and stay while they're a case and while they're infectious before they recover. Then we contact all the people that were identified as having close contact with that case, and we tell them we ask them if they're symptomatic. If they're symptomatic, they get tested. If they're not symptomatic, we know that they have 14 days within which they can actually come down with COVID. So we ask them to stay at home and not go anywhere for that 14 days, monitoring their symptoms, making sure they don't have a fever. And we check in with them every several days to make sure they're doing okay. All of these contacts get tested. If they have symptoms right away, if they never got symptoms, they still get tested at about day 10 or 12 after their exposure to make sure that they didn't become a case. That's why we have so many more asymptomatic cases amongst contacts. We're still doing that part. But as you know, restrictions on movement and restrictions on travel have really been loosened up from about May, the beginning of May onwards, and that definitely is why we're seeing surges in our cases at this time. What is mitigation? Once people are out and about, we have non-pharmaceutical interventions, social or physical distancing of 6 feet from anybody who's not in your household, restricting all public gatherings, as I said, and right now we're restricting gatherings to less than 12 outdoors of non-household members, but we're revisiting that, thinking that we need to be more strict with that, seeing as how we've seen a lot of cases from these public gatherings. School closures. Other non-pharmaceutical interventions include facial coverings whenever you are indoors with non-household members, like in grocery stores, if you're in pharmacies, healthcare facilities, etc. And to wear a facial covering or a mask, not an N95 or surgical mask, because those are needed for our healthcare personnel and first responders, but a facial covering of some sort when you're outdoors and unable to maintain that 6 foot of distance from others. Pharmaceutical measures, we don't have many. We have remdesivir, which is a drug for treating very ill hospitalized patients. We have convalescent plasma, that's another thing we're using for very sick people in the hospital. But those are really our pharmaceutical measures. We do not have a vaccine yet, but we know that there's several companies that are working really hard at a vaccine, and some of you just started doing a trial in human beings now. So hopefully by early next year, we may have a vaccine, if a vaccine is available, able to be produced. So again, the current strategies in containment, we have our ongoing surveillance. All the data that I've provided you is from our epidemiologists. We have the active case follow-up and 14-day monitoring I just spoke of for our contacts, and quarantine and isolation, which I just discussed. Again, individual measures we talked about. Hand and respiratory hygiene is really important as well. Washing hands with soap and water for 20 seconds or using hand sanitizer whenever you come in contact with surfaces other people who might have touched. And then we talked about the cloth face coverings, physical distancing, and all of the social distancing, restricting of gatherings, school closures. And now, of course, due to the governor's order, we've actually closed a lot of the high-risk activities and businesses, as I mentioned in the beginning of this presentation. So again, let's go over, these are some really nice infographics or schematics from the Centers for Disease Control and from Sonoma County. Practice social distancing, stay 6 feet, 2 arms lengths away from other people at all times that are not part of your household. And that's why many places that are open now, like grocery stores and our big box stores, as well as healthcare facilities, have very clear markings 6 feet away from one another, so people know where they can stand safely in relation to another person. Here are some other individual mitigation strategies that are really important to point out. When in public, wear a cloth face covering over your mouth and nose. Don't touch your eyes, nose, and mouth, because if you touch surfaces like door handles, or if you're in the restroom in a facility and you're touching the sink and things, and there's virus there, then the way that you would inoculate yourself or give yourself the virus is by touching your face, your eyes, nose, and mouth. So don't do that. And clean and disinfect frequently touched objects and surfaces frequently. Stay at home when you're sick. Do not go out anywhere in public. If you're sick and if you're sick enough and you think that you might have COVID, fevers, sore throat, shortness of breath, cough, even non-respiratory symptoms like diarrhea, stomach pain, loss of smell, that's a very common symptom with COVID. And there's some unusual symptoms that people get: headaches, general malaise, fatigue. If you have significant symptoms, go see your doctor to get tested. And of course, washing hands, which we've already talked about. So these mitigation strategies we've just been discussing, why has it been so hard for those in the Latinx community to actually do these things? Well, it is hard to social distance when you have to be out and about doing essential work and have shared transport like vans, where you also might have living conditions that are close, like farm workers, vineyard workers all live together in very close proximity. So they really can't social distance or be able to isolate when being a case, or quarantine when being exposed. Sheltering in place has been really hard for essential workers because you have to be out and about and working. You can't stay at home. Homelessness has been an issue that's come up too. If you don't have a home to shelter in, where can you stay? And then isolating when exposed, we do have the alternate care site where people can isolate or quarantine, But a lot of people can't afford to miss 14 days of work when they don't have sick leave or any other benefits. So these are some real barriers for the Latinx community in really trying to put into place the mitigation strategies. So here's a study I want to show. In Indiana, a survey found higher rates of COVID-19 among the Latinx in April. They found that the evidence of current or previous infection was 2% in all people who participated in the survey, but 8% in those who self-described as Hispanic or Latino. That's 4 times the rate of infection. And again, they're putting out the same messages that we are and trying to put out the messages in Spanish, in appropriate language, and through radio stations and other ways of reaching people. So the overall prevalence of infection was low here in Indiana, but 10 times higher in the Latinx population. And again, we need better communication strategies was a conclusion reached by this survey. And the survey also suggested that we should involve local community leaders, which we're also doing here in Sonoma as we move forward towards getting the word out. So why do we have this inequity? Well, we know that the barriers are felt to mitigation, I just talked about, are felt most strongly by the Latinx community. There's institutionalized racism that was prevalent way before COVID-19 hit. And the fact that we have the essential workers in the Latinx community, and the fact that housing has been a really big challenge in terms of large households that live together with the inability to really prevent transmission. And we are actually providing the alternate care site and have been able to house a lot of the Latinx community when they become cases or when they're contacts to help them quarantine away from or isolate away from family members to limit the transmission. So if you take a look at social determinants of health, you can see that Hispanic and non-Hispanic white do make up 92% of Sonoma County's population, but you can see that there are some drivers of COVID-19 here that explain these disparities. You can see the median age in the Latinx is 28, whereas in white non-Hispanic it's older, again suggesting it's the younger people who are out and about working in the Latinx, again, drilling down to that are getting COVID. But the median income is significantly less than the Latinx population. So they have less economic capital and economic security to be able to face this pandemic. And you can see here that, again, we have the same drivers of other health outcomes that are at play, the same social determinants of health that speak to other illnesses and other diseases being higher in the Latinx also drive COVID. Latinx individuals are more likely to live paycheck to paycheck with limited ability to call in sick when they need to work. They're more likely to be uninsured with delays in access to health care, and they're more likely to live in large households. That's what you see right here, less likely to be economically stable, more likely to be uninsured, and more likely to have large household sizes with the inability to be able to really shelter, or that is protect the family. And that's why the alternate care site has been so important. So let's look at all-cause mortality and excess death January through May 2020. This is looking at some sort of other factors. As you can see here, February 10th to May 17th, there were 0.8% more deaths than expected. So not a really significant difference. This is basically the 3-year average, 2017 through 19. This is when the first COVID-19 case was diagnosed in Sonoma County. This is when we placed the shelter-in-place order. And you can see deaths have been about the same, maybe a little bit higher, but on average, as I said, just about 1% more deaths than expected this year from the 3-year average from years 2017 through 19. And in fact, if you look at December 30th through June 1st, you can see that there's 2% fewer deaths than expected in that time frame. March 2nd through June 1st, we had 2% fewer deaths than expected as well. So if you look at the entire time, our deaths, and these numbers are fairly small, but we have not had an excess number of deaths due necessarily to COVID or the byproducts of COVID during this time. So you can look here that the number of deaths in 2020 compared to the 3-year average 2017 through 19 by leading cause of death, by age category, and by race, ethnicity. We're going to talk about this. Includes proportional increase or decrease in deaths from January through May 2020 compared to the 3-year average from before. So if you look at it, the excess death overall, February through April, there are 3% more deaths than expected in the overall excess deaths. But you know, this varies, and these numbers are kind of small. So sometimes it's really hard to come to conclusions based on smaller numbers. But if you look at January through June 1st, 2% fewer deaths than expected. So basically, not a big difference. But I do want to note that they're looking at the excess deaths by race and ethnicity. You can see that in most of the months here, in the Latinx, there were excess deaths, and very few, if anything, decreased number of deaths in this time frame. And in the white non-Hispanic, you do see some excess deaths as well in February and in April. But the epidemiology team is still looking at the leading causes of excess deaths specifically for the Latinx population. We should be able to share the results of our analysis with you shortly. So let's move to the actions that we've taken, because in public health and in the department, as well as for our community, we've actually done a lot. Our epidemiology team, as you can see, has been published updated data on the socoemergency.org website about the impacts of COVID-19 in the Latinx community. You can look at the Road to Reopening dashboard, and the website we can display for you at the end of the presentation. And all of the indicators that we've been looking at are available on the dashboard. It's a very comprehensive dashboard that looks like at age, at gender, and underlying conditions, looking at hospitalizations, looking at exposure, symptoms, the region where cases are occurring. And I really highly recommend that people visit the website to see what data we have there. And why is it so important to track this data? Because without this data, we wouldn't know where to focus our efforts. We know now we need to focus our efforts in the Latinx community that's out and about, working in the specific work areas that I've mentioned, in the age groups that I've mentioned, and try to mitigate spread in large households and in work sites.
Real quick, Dr. Mase, we just want to let you know that you have a few minutes left to wrap up your presentation.
Right. No, I have my timer on here as well.
Okay, perfect.
So I think I'm almost through the slides as well. So the Latinx Health Workgroup was convened in May 2020 in response to data showing disparities in Latinx communities. And we have community leaders who in health in all levels of their organizations that represent communities here in the Latinx Health Workgroup. And they're advising county staff on culturally responsive communications, pop-up testing, community needs related to COVID. We also have used a really far-reaching holistic community outreach, engagement, and wraparound service program. Community engagement in many ways. We have had culturally responsive services to support people to safely comply with isolation and quarantine orders. As I mentioned, we have the alternate care site, which gives people the opportunity to isolate and quarantine in separate rooms away from their family members to try to limit transmission. We have done case management, with specifically looking at needs, care needs and case management, wage replacement, food, etc. We also, there is also a Latinx outreach group that Supervisor James Orr has put together that's been around longer than COVID, that elevates concerns of Latinx community to the local government level through a coordinated effort, provides translation services for everything we put out in health, needs translation appropriately, accurately for the Latinx group and community. The coordinated efforts of this group helped to spur the creation of a county office of equity. And Alegria de la Cruz will be serving as the interim equity officer beginning August 12th. So we're really excited to have her on board as the equity officer for the Latinx community and serving this population. We've also had District 5, and that is Supervisor Linda Hopkins, Agriculture Industry Stakeholder Group. It meets every week or two. I'm part of that stakeholder group as well, where we give updates on COVID-19 and where we are. And this group includes industry leaders, business organizations, nonprofit organizations, agricultural workers, stakeholders. We also have partnered with Supervisor David Rabbit in this group, as he's responsible for business recovery. And a lot of attention was put towards Latinx agricultural workers through this work group, and it has also spurred further work. We've been providing communications in Indigenous language interpretation services at the Latinx community testing events. We've done a lot of pop-up testing through our nurses in disease control, a different area specifically targeted to the Latinx group, and near grocery stores in Roseland, in Cloverdale, many, many different places. We've been disseminating information via Spanish language media outlets, coordinating culturally relevant messages, as you can see, putting out ads specifically in Spanish, billboards, etc. We've also hired a lot of bilingual and bicultural staff. I think it's really important to note that, especially amongst the contact tracers, those are people who are following the contacts, giving them advice, ensuring that they get tested, following them during their 14-day quarantine. We've hired 19 bilingual staff, 2 intake workers, 3 nurses, and we still have 9 contact tracers, 4 intake workers, and 3 nurses in the bilingual staff that are being hired. We have had 16 pop-up testing events since May 27th. And this is really great because we've actually found about 3.5% of people we test being positive. And we're using word of mouth messaging to bring out people to get tested. This has been really, really instructive, as you can see. It's in Santa Rosa, Petaluma, and Healdsburg that we found the most numbers of positives. And we plan to continue expanding community-based testing. And this Wednesday, that's 2 days from now, there'll be pop-up testing at the Monte Rio Community Center. And this Saturday, August 1st, at Petaluma St. James Church. That's not yet confirmed, but that's the plan. And Saturday, August 8th, at the Flowery School. Again, not yet confirmed, but we will be putting out the message. And we'll continue to do this pop-up testing because the yield has been so great. In addition to community sites, we're conducting testing at workplaces in cooperation with employers. When there's a positive person in a work site, our nurses go out and test all of the people who've been exposed. And we ensure that all cases are isolated either in their own homes or in the alternate care site, and that all contacts are quarantined. And the testing sites are informed by GIS data and the Latinx Health Work Group. Oh, this photo was intake table at Andy's Unity Park in Southwest Santa Rosa. So we are also have been presenting a plan for ongoing COVID-19 response to the Public Health Division, to the Board of Supervisors. We've already had one meeting about it to put forth our plans for having a complete COVID-19 section just for this response. And we expect to hire an equity manager specifically to address disparities in the Latinx and in other groups as part of our structure. We're having weekly meetings with employers and leaders, as I already suggested and presented, outlining industry-focused strategy to provide testing at work sites, coordinating with the Employment Development Board and labor advocates to provide information about paid sick leave. EDB outreach to Latinx businesses has been in many forms. There's been education on health protocols, face masks, posters, resources in Spanish for employees to stay safe and access funding, weekly Zoom calls in Spanish with Latinx business owners to update them on health orders and resources for employers and employees, interviews with Spanish language media outlets, including television, internet, radio, Facebook, and Zoom, connecting business owners with Sonoma County job links to access resources for employees, including funding, training, and help with finding jobs. And the actions have been in partnership with the Hispanic Chamber of Commerce, Latino Alliance, La Luz Center, Los Cien, SBDC Centro Hispano, El Poder de Saber, Latino service providers, and Petaluma entrepreneurs. So lots of different stakeholders have been involved in our outreach activities with the EDB. As you can see, here's a picture of EDB staff engaging with Latinx businesses owners on site. So what's still needed? Well, we really need to have some ongoing systems change work, making housing more affordable, to address economic insecurities and systemic racism. And, you know, as I said, we're working very hard to put together the measures, policies that are needed to address all of this. So let me start there. I think I'm actually a couple minutes over, but I'll stop sharing my slides as well so that we can go to a Q&A. Thank you.
Thank you, Dr. Mase, for joining us and doing that wonderful presentation. I think we got a lot of good information out of there, and we'll now jump into the Q&A session. So we did get a few questions in our little form here on the bottom, so I will go ahead and read the questions off, and then you can answer them, Dr. Mase. So let me go to the first one. It looks like we received a question earlier asking, when County Health asks a COVID-19 patient about activities which could indicate exposure, do you believe that people feel free to answer honestly, or is there social pressure to say no activities?
That's a great question. It's something that we've dealt with not only with COVID, but with tuberculosis, other infectious diseases. And I just want to encourage everybody to be truthful. I think people are worried. There's some fear about admitting potentially that they were part of, am I unmuted? I hope so. Okay. Yes, okay, good. So I think that there is definitely fear with people admitting that they've been doing things, activities that are more high risk maybe, but we really need for our data to know where people have been. Like, for example, if people hadn't admitted to going to gatherings, we wouldn't realize that a lot of cases are happening at family gatherings and gatherings of friends and work colleagues and things like that. So I agree it's a big problem.
Yeah. Let's go to the next one. Let's see here. So Wendy asks earlier, she mentions, thank you, Dr. Mase, for your work in our county. My question is in regards to COVID-19 test takers in the community being paid versus volunteer translators. And essentially this person is asking if it was considered to make these paid positions, and could there be bilingual and bicultural paid testers?
Well, I'm not sure about what it's meant by testers, but those are paid positions that we're hiring amongst outreach workers. There's community health workers. There's a flyer that was put out about a month ago asking for people to apply, especially bilingual applicants, specifically for community health worker, to be a community health worker for outreach, contact tracing, dissemination of information, even testing. So we have hired from that pool. That's where all those bilingual hires I showed are from.
Mm-hmm. Perfect. Yeah, thank you. So we have another question from Shelene. What is being done at a county level to ensure that test results are being notified in a timely manner? I know that it can take up to 10 days for people to get results, which means they could have possibly exposed many people in that time frame.
Another really excellent question. I want to let people know that the testing delays that we're having right now are real and they need to be addressed. However, these testing delays are problems that are happening at a national and a state level. This is not a county problem. It's a problem with testing supplies. It's a problem with Quest Lab, which is the lab that does the majority of our testing for the nation, that is, being really inundated with tests and really being delayed as a result. OptumServe right now, which is a state-run testing centers, are behind about 1 week to get an appointment. So I agree that if you're somebody who has symptoms, you should not be going to OptumServe. OptumServe is for people who just want to know what their test status is, who feel well and who aren't contacts or exposed. And what we're doing in public health is prioritizing people who've been exposed to cases, that's contacts, and very ill people, as well as healthcare workers and first responders and essential workers for testing through our public health lab. Our public health lab has a much quicker turnaround time of up to just 72 hours or so. And we are working on improving that as well with increased staffing for the lab. So we can do more and more testing in-house instead of having to send it to other labs. So it's something we're working on. State of California is also working on having a lot more in-state capacity to make testing materials, reagents, ensure rapid turnaround times. 40 extra labs have been added to the list of labs that can be used for testing. So a lot of work is being done in this area, and hopefully we'll see that bottleneck being released some.
Thank you. Thank you for that information, Dr. Mase. We have also Michelle asking, do you have a sense of what level of care, whether primary, urgent, ED, that Latinx patients are seeking? What symptoms are the patients presenting with? Are people asymptomatic, moderately ill, or bedridden?
Yeah, that's again a really great question. I didn't present the data on different symptoms. Across the board, overall, people are presenting with fever, cough, sore throat, shortness of breath, but they also are having non-respiratory symptoms. There is a much greater proportion of asymptomatic patients amongst the Latinx group because we're testing all of the contacts. Whether they have symptoms or not, anybody who's a contact or case is getting tested in our county and has been for the past 4 months, which is why, because the Latinx community has much greater numbers of people who are contacts, there's much greater percentage of asymptomatic. Children also tend to be more asymptomatic, with 40% of kids being asymptomatic. And I think 90+% of the kids are Latinx community members. Mm-hmm. So definitely we're seeing more asymptomatic cases in this group because they're younger and they're contacts.
Mm-hmm. And I think all the more reason to be being precautious, you know, washing hands, sanitizing, and wearing a mask for those reasons, right?
Yes, exactly.
So we'll take one more question now. And for those folks who did not get their questions answered during the session, we will send these over to Dr. Mase and release some answers at a later time, along with this webinar recording that will be up on our website. And I believe I did throw in the link for the website down there in the chat. If not, we will send it again. Real quick, let's see here. So we have this question from Marjorie. So what are the alternative care settings available to Latinx community members to isolate or quarantine? What are the financial supports for community members who need to isolate or quarantine?
Oh yeah, very good question. We did have the alternate care site at Sonoma State University up until about 2 weeks ago. Now there's another alternate care site that's identified. It's in Healdsburg, and we are able to provide transportation, get people who don't have any other way to isolate or quarantine into a single hotel room at this time.
Mm-hmm.
With a private bath. We're still providing meals and services for individuals who need to isolate and quarantine to make sure that if they're ill, they get transferred for evaluation at the hospital. And that new location has been up and running for the past week or so. And in fact, we have a lot of people there now. So both people who are cases who need to isolate and contacts that need to quarantine can be placed in the alternate care site at this time. And there's no cost to the individual.
Perfect. Thank you for answering these questions, Dr. Mase. I know the community has a lot more of them, so we will send them your way. But for now, I will pass it over to Dr. Gonzalez for some more information about our upcoming webinars. But again, I just want to thank Dr. Sundari Mase for taking the time out of her day to join us for this really important series. So, Dr. Gonzalez, por favor.
Thank you very much, Dr. Sundari Mase, for your brilliant, informative information. And thank you very much for all the endless hours that you've been putting on trying to help our community. Thanks again. And we couldn't start our Latino Health Forum this year in a better way than having Dr. Mase with us. Thank you again. So we are going to have tomorrow Dr. Michael Valdovinos, and it's going to be a very interesting presentation about the Latinx health behavior and the COVID-19. As you know, this pandemic is causing a lot of mental problems between anxiety, depression, isolation, and so on. So Dr. Valdovinos will be with us tomorrow at noon, and thank you very much for your participation. And we will keep in contact, so we'll see you tomorrow. Thank you very much again, and take care. Don't just be careful. I mean, it's a matter of some time, and then we will be able to do our normal life, hopefully. Thank you very much, and see you tomorrow.
I do want to make a quick announcement. So thank you very much, and everybody who participated in our kickoff event for the Latino Health Forum. Just to let you all know, you can still register. So if you have anybody that's interested, you can still register at latinohealthforum.org. I put it below at the chat. Also, these videos will be recorded and they will be translated in Spanish, and we will have the English version on our website and on our social media pages. Thank you all for attending.
Thank you.